I will introduce the speakers on behalf of you. The next presentation is Psychosocial Interventions in Burn Survivors, and this will be presented by Deblina Roy. She is a faculty in psychiatry nursing. She had more than 60 publications, and she did a lot of work with respect to mental health issues during COVID pandemic. And she is also doing a postdoctoral research. She is developing a psychosocial intervention module for the burn survivors to address the psychosocial issues. I hope she will be elaborating more about the psychosocial intervention strategies for burn survivors. So over to you, Dr. Rohit, to invite the speaker and introduce the topic.
Hello, I invite Deblina Roy to start the presentation.
Very good evening to one and all present here. I'm Deblina, and thank you for this elaborate introduction to Sujit sir and Rohit sir. And I hope to present my slides now.
Am I done? That's it.
I hope it's visible.
Yeah.
Okay. So, psychosocial interventions for burn patients. I had been interested in taking care of this situation since I was a young student in my bachelor's while taking care of patients who were suffering from burn injuries in PG Medical College, Calcutta. And since then, I thought this is an area where a lot of people feel stigmatized or even a lot of fear. But then somebody has to do this. Somebody has to care for them. They are the people who are often unheard and are very much disabled to actually advocate and vouch for themselves. So we are going to talk about understanding burns and effects on life, how common psychosocial, what are the problems that affect people with burns, what works for them, strategies to manage the problems, how to build confidence among those people, social inclusions, what are the gaps, and how to go forward in long-term burn care. So global burden of burns is quite significant and disproportionately higher in the low and middle economic countries, with a high incidence that is estimated around 11 million new burn injuries that occur annually. Over 30,000 people every year suffer from such severe burns that require medical attention almost every day. Burns also have a high mortality rate, and which is estimated about more than 1 million deaths, around 2 million deaths per year. Disproportionate impact on LAMEC countries because of lack of resources and a lot of non-fatal burn injuries, which is almost 70% of the burns that occur in the low middle income countries. And then we also see a lot of regional disparities in the African and Southeast Asian regions, which together mostly accounts for most of 2/3 of the global burn deaths. So what happens when a person gets burned? Most common type of burns are thermal burns. They kind of give lifelong disabilities, prolonged treatment, and concurrent disabilities. It has a strong economic impact on the livelihood of the not only the patient, but also the family. And it has got some severe psychosocial and psychological impacts that is associated with burn injuries. So what we can see here is in the acute phases, persons suffering from burns have a high risk for infection. There's a loss of skin barrier, which creates more vulnerability, and fluid loss, which can be life-threatening in an acute phase. Then due to the burns, there can be a lot of reasons. Thermal burns due to smoke and hot air and inhalation. There can be lung injury, which significantly compromises their ability to breathe and survive, lead to metabolic changes, which can create hypermetabolism, muscle wasting, weakened immunity, leading to further infections, and the healing often leads into neuropathic pains, chronic pains, nerve damage, and a lot of scar tissue. I just tried to put in some pictures from the internet for better referencing. Then what we can see here is a lot of functional and cosmetic disfigurement also occurs among the people who undergo such kind of injuries. So the scarring, most commonly, that's what my patients have reported. The scar is difficult to manage. It creates contractures. Sometimes they are itchy, they are painful, they're very sensitive to light, temperature, any kind of clothing. It's very difficult for them to manage in those situations. Then contractures significantly limit their ability to move the joints. That leads them into developing further disabilities, even if they have mobility. But that is severely impacted. Tightening of the scar tissue, oftentimes, even if there was mobility, the lack of exercise or the scare or the fear of injuring themselves, they haven't exercised much, so there is tightening of the scar tissue, reduced mobility and disability for the same, and thermoregulation problem, like what kind of clothes to wear, anything in hotter or colder temperature, it's very sensitive for them. Then sweat gland damage. Therefore, most of my patients and the patients who suffer from burn, they complain that they have they feel very hot because they're unable to, their sweat glands are damaged due to the burn injury on the surface of the skin, and impaired temperature control. Therefore, they're prone to developing fevers and sometimes even become hypothermic causes. So now what we can see is that based on the type of burn injury or the cause of the intent of the burn, we can see that the psychological impact can be very different. For a case of a suicidal burn, when a person is intended to end their life and they've attempted or got burnt in that way, there is a clear-cut psychological distress already ongoing in that case of patient. And that requires urgent psychological management immediately to reduce the suffering. If there is a homicidal burn like a vitrolage or an injury that has been caused by somebody else, there is a complex psychological care process that goes on and requires immediate intervention from a qualified and a trained mental health professional. And then there is a significant necessity of evaluation, ongoing evaluation and assessment, so that a tailored intervention can be planned in those cases. In case of accidental injuries, there is a lot of confusion. Immediate physical care is mandated, and immediate psychological first aid is necessary to mitigate the crisis situation. Unanticipated consequences can be overwhelming and most likely leads to a lot of psychological problems later in the stages. So what are the common challenges that we assess? So first thing that we come across is that mostly there is a lack of team effort, and in the beginning, when somebody undergoes a burn injury, they're necessarily seen by a physician, they're seen by a plastic surgeon, they go to an orthopedician, but the referral to a psychiatrist or anybody from the mental health profession or the team is quite later. So, but we can see that there is a significant need that in an immediate or an acute stage as well, if the psychological factors are taken care of, it can actually improve the wound healing and the outcome of the burns. The team must include a psychiatric nurse, at least a referral to psychiatrist for licensed psychiatry for every case, if that is there. The documentation and prompt intervention not only will help the patient but the family, because the family is also uniquely affected when there is a burn injury. They have not anticipated what is going to happen, how much it is going to cost, and how the person's life is going to change completely after the injury. So what we can see here is that there is a lot of issues in the body image due to disfigurement, disability, complications, and we can see that depending on the location of the burns and the severity of the burns, most of the people often lose their vocations. They are unable to continue with their jobs. The self-esteem is low. There's kind of a social stigma, and people look at them in a different way, which is what most of my patients have said. They've covered their faces, their body parts. If it is in a visible area where the burn is, they always try to cover it up. so that they don't like questions that come up to them when such kind of cases are there. Then this also can lead to different kinds of comorbidities that are unavoidable in cases of large injuries, then PTSD. A lot of the patients who have undergone severe burns often talk about the moment something happened, or they vividly remember what happened at that time and how it affects, and it comes to their dreams and ongoing depression and anxiety, because a lot of them do talk about that. I used to do so many things for my family. I had dreams and hopes, and now because of this injury, I cannot function the way I used to. And then changes in intimate relations. A lot of patients do tell about that, how their relationships change with their partners, their spouses, and that significantly affects their life as well. Then we can see that functional changes. So chronic pain and itching becomes an important or an unavoidable part of their recovery. Scar contractures, mobility limitations, thermoregulation issues. Then we go to reconstructive surgery, where I'm basically taking my patients from. There is surgery and grafting. So they also have to undergo another traumatic experience where an autograft is taken from their skin and then it is placed to the other part of their body. Also takes time for recovery. Scar management. A lot of cases come for contracture removals and scar management. Those people often say that, oh my God, this is an expensive surgery. I have to arrange so much of my funds to even afford it. And then pressure garments, this adds to their expenses. And sometimes it's not that nice to look at. That's what they say. Medications, anxiety, and a lot of avoidance. So because of all these burdens that they feel, they want to avoid talking about it. They try to avoid the situations where they might have to answer questions. So they avoid people as well. They avoid their family members. They avoid the friends that they used to have. And also that leads or aids into the depression. They have an image issue. They stop going to the social functions. They stop feeling included in the group that they previously felt they belonged. So financial challenges become an important part of their life. So I had a patient who used to own a car company. So he used to give out on rentals and drive cars as an occupation. But then after his injury, he's got severely limited while doing that thing. So he couldn't earn the amount of money that he used to make before. And then people are also fearful about employing him. They consider that his expertise might not be that good anymore. So there is a lot of financial strain. And the caregivers also feel that, how are we supposed to manage the situation? He's not feeling all right. He might not be able to function, and we have to cover for him in most of the cases. Relationship changes, where he was a leader of the family. Now he has to accept help from other people, which makes him feel low about himself. So the self-esteem has gone down. And then vocational rehabilitation. So now this person is relearning to drive his car again. Now he takes only his family out if they want to. And that's how he's learning to live again, where he was most comfortable. And then there are PTSD and flashbacks and stresses about the occupation and the finances that are involved in removing the scars, managing the itching, getting an air conditioner installed because he cannot live in the hot environment anymore. So definitely that's something which adds more to the financial burden. What actually works? So in the acute phase, on the early intervention, the crisis management takes up most important role. The goal during this phase is basically hospitalization and immediately help the family to cope with the immediate crisis. So here, if psychologist or a social worker or psychiatric nurse could be a core team member in the burn to manage these kinds of situations, assess and document any kind of pre-existing psychological conditions, their coping mechanisms, and what kind of social support actually exists for them. Supportive psychotherapy plays an important part. Here, where there is an immediate trauma and overwhelming nature of the injuries, the focus should be on the present. Interventions should focus on immediate concerns like sleep, pain, anxiety, reorienting them to the hospital environment, sense of control over the small things that can be empowering at this stage. Normalizing the feelings, acknowledging that their fear, grief, guilt, anger are normal responses to such a traumatic event. Pain anxiety management, non-pharmacological interventions like hypnosis, relaxation techniques, deep breathing, guided imagery, music therapy have shown to be effective in reducing procedural pain, anxiety, and that can be used to supplement the medication. The family needs to be involved. The family is a vital source of support at this stage of the crisis. The family members need to be educated. They should be given honest information regarding the patient's treatment, the condition, and long-term prognosis. For the family members also, they might experience the kind of range of emotions that they have never experienced before. It's important to acknowledge the stress on the family members and provide them emotional support and resources for if whatever they need. Because these vulnerable moments in the healthcare setting are also very important for the environment and overall recovery and the perception of healthcare that the patient receives. Distraction techniques can be taught to the family members as well as the patients, so that when they are able to manage them, virtual reality therapy can be given. And there are many tools for anxiety management during procedures, and definitely pain management before the procedure even happens in the hospital would be absolute necessary for the patient to feel a bit comfortable. So what happens when the immediate crisis and the hospitalization is over? The patient is stabilized, the wound starts healing. The patient moves on to the intensive care unit, to the rehabilitation unit. The focus shifts from coping with a new life and societal integration, because now the person feels that something has changed in them. They might not be able to, they don't look the same they used to, they don't feel the same they used to, they can't move the things that they used to before. So the strategies to manage such problems, most challenging part is body image and self-esteem. So looking into the mirror can be an assisted activity where a person prepares, a healthcare provider prepares the patient to look in the mirror before they look into the mirror after the injury first. So body image issues, dissatisfaction and depression and social isolation. So every time you look in the mirror, sometimes the patients might feel very sad and they feel like something has been taken away from them. So in those cases, cognitive restructuring would take a very important part to minimize the suffering, to change the pattern of their thinking, and sometimes even aesthetic measures, just the way we can see in this picture in the slide, can change the perception so much and can make the person feel better about themselves. Then building confidence. So I have taken this from a study. So step, self-talk, practicing positive self-affirmations, tone of voice, speaking with a confident tone, eye contact, maintaining eye contact to control the conversation, and maintaining a good posture to project confidence can be a stepping stone, because all these areas often feel deficient while the patients come back for their treatment and their therapies. Social inclusion. So addressing PTSD, which is a very specialized area, definitely needs to be taken care by psychiatrists, need to take treatment for that. Then trauma-focused therapies like EMDR, CBT are very useful for PTSD, which affect burn survivors. And exposure therapy, gradually safely exposing the patient to trauma-related stimuli, can help them process the event and reduce the avoidance behaviors. But it is really difficult because I've been working on it, and it is very important that you be very sensitive and very slow while progressing for EMDR or exposure therapies. Social and vocational reintegration. This is where I find that we need to work so much more on. The return to daily life, work and school is a major milestone in case of patients who've undergone significant burn injuries, and they are also a source of significant anxiety. They might be asked so many questions and comments and words from other people, which they might not be ready to face at this point of time. So community re-entry programs are actually very necessary in certain countries, which is available. And vocational rehabilitation, like supervised working environments, occupational therapists and vocational counselors can assist the patients in adapting to their work environment and find new employment, which can often be very challenging. Peer support, formal peer support groups, like groups where different burn injury patients can come together with a similar experience, can be extremely validating and empowering. That makes patients feel seen and heard in a lot of cases. And support groups or informal support groups can help patients realize that they are not alone and share the coping strategies and build a sense of community. Therefore, they can find support not only in the system, but outside of the system, the formal thing. Then long-term management, chronic challenges definitely include psychological challenges because the wound has healed and it's stopped bleeding. The pain still persists in the mind and in the body. Ongoing monitoring for depression and anxiety and PTSD is a necessary intervention that needs to be done. And psychological screening should be an ongoing part of the follow-up care for burn patients. Early detection of mental health issues is critical for the long-term quality of life. Psychosocial rehabilitation definitely can include art therapy, recreation, and adaptive sports, assessing chronic pain and pruritus, adjusted playing or a group. Definitely participating with others can make them feel validated and an important part of a group, therefore increasing their confidence, and then themselves participating in activities and play and sports can be significantly empowering. Sexual health and intimacy becomes an important part and very significant part of life when such kind of injuries have happened. The changes in the body image and physical function, they impact intimacy. Therapists and counselors can help the patients and their partners navigate these sensitive topics and find new ways to be intimate, to be able to share the problems with their partners and their family members, their close family members, little young children. A lot of times, the change in the body image affects not only them, but also the family members that are a part of it. So definitely they are going to require an assistance in this. And very sensitively, we have to mitigate these areas so that the reintegration becomes possible. The person finds confidence and the vulnerability to be present with their partners at that time. Way forward, what we can do is definitely the advancing medical technology and research are an important area. Tissue engineering and regenerative medicine is doing leaps and bounds, whereas new techniques of plastic surgery, different kinds of bioengineered materials for burn management have become quite available in various countries, and even in the low and middle income countries, we can see such techniques being used for management of burn cases. Smart dressing and biomaterials have improved the chances of wound healing and reduced the chances of scarring, which are very important. Precision debridement, these and nanotechnology improve the condition of the scars. They limit the possibilities of contractures, enhance the recovery time, right? So these things definitely are the way forward so that the healing can become sooner and faster, but definitely the caring of the mind might take a little more time. So prevention and first aid education becomes a part of the primordial prevention for burn cases. And social initiatives require collaboration between the places that have very good burn care. International collaborations and trainings can help the specialist learn better techniques and implement them in their own areas. Resources and appropriate guidelines for management of severe burn injuries, SOPs and tailor-made interventions are definitely necessary. And then along with all of these things, a multidisciplinary team intervention to take care of the psyche of a person who's undergone a burn injury digital health platforms where they can talk about it, create a support group and work on it, early and consistent psychological screening almost at every follow-up, and then reassuring multiple times that they can definitely talk if something bothers them, if their sleep quality is poor, if they feel more pain, they're always welcome to talk about it, and empowerment programs so that they feel that they can do better with their lives even after the injury. The future research must shift from focusing solely on survival metrics to outcomes that matter most to the patients, the quality of life. Scope of telehealth monitoring and accessibility definitely is life-changing and provides a sense of continuation of care. Dedicated programs for support and prosthetists and mental health care needs to be formulated in policy. So a lot of cases we see that this is not part of the policy, so a lot of care doesn't get provided. Fortunately, we have more and more telehealth initiatives like eSanjeevani. If the patient is unable to come themselves, they can contact the doctors online. They can ask for assistance. Psychological support is also available remotely nowadays. Online consultations and tailor-made application-based services are also becoming a part of the community reintegration program. And these are the areas where evidence needs to be created and work can be done. So what can we do? Consensus-based core outcome sets. We definitely need more collaborations with patients, clinicians, researchers, that clinical trials measure what is most relevant for burn survivors. The quality of life, including functional outcomes, pain, scarring, and psychological well-being. Longitudinal studies are needed for the long-term effects of burn injuries exceeding beyond a few years post-injury. Longitudinal studies will provide the valuable insights into the chronic challenges of pain and scarring and psychological distress, guiding development for effective long-term interventions. Patient and survivor involvement feels to be the most important part because their lived experience is invaluable and definitely should inform research priorities and treatment protocols and design of support programs. So in conclusion, I would like to say that addressing these persistent challenges require comprehensive long-term and multidisciplinary approach that extends far beyond initial hospital stay. Organizations like Phoenix Society for Burn Survivors, Shiro's Hangout in Lucknow and North India, Burn Healing Foundation, Interburns Asia, Acid Survivors Foundation India are doing their job, but the numbers are very small. The kind of incidents or the prevalence of burn and injuries are way much more, but the organizations that actually support the burn survivors is very small. So I would definitely request all the people who are present here to think about funding and doing more research and awareness regarding burn management and changes for public attitude for employing people with burn injuries and disabilities. And as for long-term psychological needs of survivors, their families, helping them navigate a lifetime of recovery. Movies like Chapak can bring to notice the challenges that are part of the burn survivor. And at the end, lending a helping hand can often reduce the pain in most difficult situations. Sensitive and empathetic nursing care can definitely make a difference. Thank you.
That was an amazing presentation, Deblina. I would like to invite the audience and the participants for any questions and comments.
Yeah, I would like to say I just, I work in psychiatry for nearly 40 years, but I haven't seen that many patients, and I'm quite amazed how how you work in a center like this. I think you must be working in a very big hospital where you see enough patients to be able to support them, because we don't, let's say, I'm come from Germany and the UK, but we don't see that many that we would really be able to have this wide and comprehensive support. So I don't know. So yeah, how can you manage this? Is it psychiatry or setting up special centers, or But then again, if you set up special centers in big cities, so what is the rural? What's the rural support then? So I don't know. It's a bit of a compromise to do.
Yes, that is the challenge that we are facing, because I work in KGMU, which is a large center, and we've got a pretty big department of plastic surgery where we see a lot of burn cases. And I've been fortunate to be able to work with them and also be a part of their lived experience through their journey of recovery. But yes, I think what work I'm doing is actually not that significant when we see the amount of burden that is present. But at least we can try. I feel that we can try to prepare modules, to train more staff, to create policy guidelines that will actually allow more nurses to work with their specialized training and directly with the patient care. And I would definitely advocate for live in psychiatry, because majority of the patients that I do see in my practice are very shy of coming and discussing their concerns with psychiatrists. And even after referrals, sometimes it's difficult. So LASN and then our department of psychiatry actually collaborates very well with the department of plastic surgery. And whenever there is a referral, people make sure that their patients are attended and whatever care is necessary is being provided to them. But yes, we are getting there. I wouldn't say we are there yet.
Okay, thanks.
Deblina, there is another question in the comment section mentioning about, this is a question from Surabhi Chatterjee. They're mentioning, as a part of triage team, due to resource limitation in LMICs, would you suggest a triage on the basis of burn percentage and the first point of contact? Since psychiatric care might not be easily available, including training for both psychiatrists and plastic surgeons? We'll take the
Yes,
first question. There's another question. We'll take that next.
so
Please go ahead.
definitely that can be possible. What has happened is that the moment we see that we require somebody with a mental health expertise, it can also be somebody who's a psychologist or a nurse with a training. They can work in this triage, and definitely whenever they can screen the cases, and they can always refer to the doctors. I believe that even if there is resource scarcity, we could train more people. We don't have to be specialists, and they can definitely support the cause if that is the case. So yes, that would be a thing where we don't put all the burden on the doctors itself. Let's share the burden. That's what I would say. Like
I would like to
having
also
more
add that
resources out there.
maybe, yeah, I would like to also add that maybe social workers and
Yes,
people who are,
definitely.
definitely specialized in medical and psychiatry can be the first point of contact from there on to transition from the care between the psychiatrists and plastic surgeons.
Yes, that's a possibility, and I guess that should happen.
All right. We'll go ahead with the second question. They're mentioning as anything for the caregivers in any way, since they are too often directly and indirectly affected, especially especially in patients with vitriolage. I believe the question is about the training and the resources for training for the caregivers.
Yes. So I would like to say that when such kind of, this is basically a crisis. Whenever the case of vitriolage is coming, it is a crisis situation in terms of a medical crisis, in terms of a psychological crisis, and the family doesn't know what to do. So awareness programs are there, many of the cases, and recently the government of India has even instituted vitriolage to be a disability that qualifies for getting a government service. So I would say that the policies are happening, but we need to prepare comprehensive SOPs for such cases so that their families can be incorporated and they can also provide the necessary support that the patient needs, and they feel supported as well. I don't exactly know what to do at this time, but I think preparing SOPs and training more people to provide the resources at that time would actually make a difference in cases of vitriolage.
All right. Thank you for the
We have to move
answers.
forward.
There's another question. I'm sorry.
You have to move forward, I don't know.
Right.
Yes.
There's one last question. We'll just take that with a brief answer. Have you had any experience with EMDR and TFCBT in burn patients?
So EMDR, because I'm not very well trained in it, but I have read articles or literature where this is actually helpful. But in case of CBT, yes, we have tried it and it does work. Especially positive affirmations and thought restructuring can be efficient for them. But yes, a lot of reinforcement is needed. In case of exposure therapy, I myself have taken my patients, with permission, of course, to places where the support groups and the people with burns are present. They are working or they are employed. So I can see that the way they interact with those people who have accepted their situation and are already part of the employment program, that gives them empowerment, that gives them hope that
All right.
we can also
Great.
get better. Yes.
Okay. Thank you. Thank you for the presentation. It was an amazing insight into the way we can have multidisciplinary collaborations between multiple